allowing the MV to dump the ASI questions that are self-administered to the patient into this assessment, pre-populate this, and then have this just ask the counselor to get the additional items so that it's really done with both direct patient assessment and then counselor judgment. But I think you've actually gone a step further, and I think it would be an excellent grant proposal to NIII or NIDA. For me to do. For the next generation to do, please.
You mentioned this is open source. Could you just talk through what are the terms of the license?
Sure. So and I think we've done enough of the interview to be able to talk about these issues, and also we want to take 10 minutes to get to the survey. The SAMHSA funding has specified that the field get access to the software in a very broad fashion. Even that vendors, other software vendors in the behavioral electronic health record space have access to this so that they can put it in their software. And it's been built so that those tags on the inputs and outputs are all easily accessible to them to put into their own software so it can look like their product. And ASAM will allow them to do that and maintain a certification process so that it's still the ASAM criteria. Pricing has actually been studied. Is that the next part of your question?
Actually, no. Keep going. I'll ask the question.
Okay. Well, one thing about open sourcing, is that more what you're asking about?
Yeah, actually the source code itself.
All right. The source code will not be available for the decision tree engine except to researchers. So people who are going to study how the decision tree logic is working and the thresholds for sending a patient to residential versus level 4, that's going to be available to researchers because we want them to play with it in statistical analyses and other hypotheses to tell us if there are better ways to do this. And the beauty of this being a cloud-based or server-based application that you're really looking at through a browser is that we'll be able to update this constantly. And you won't even know necessarily that it's just been updated last night, but you'll get the most recent version all the time. But the engine itself, the decision tree, is going to be compiled. And the reason is ASAM does not want every state or every managed care company to start tweaking its own version of the ASAM criteria. They're doing that on paper now, and it's not helping. So we were advised, in the Harvard Business School group was advised to protect the integrity of the decision tree and always be sure that there is one set of ASAM criteria. They can constantly be improved and upgraded, but there should never be multiple sets of them.
Okay, so just to clarify, this really is an open source then?
It is a hybrid of open sourcing. That's what we were given that term by the open source health group, and that's what we decided to do.
Your entry pricing, please.
What's that?
Or their entry pricing model.
Oh, pricing. What I'll say about pricing is A, it's not finished. B, ASAM will be the final arbiter of what the pricing is. FEI will propose it. The business school actually did a full pricing, multi-level and aggressive, moderate, and liberal pricing strategies. And they recommended actually a pricing per use and also by size of program. We're probably not going to do it that way. We're probably going to simplify it into several tiers so that a mom and pop shop that has a couple counselors or a single practitioner's office that's got 100 evaluations a year is going to pay really a very affordable maintenance or service fee. But programs that have 1,000 or more will pay a substantially greater sum. And this is not to own the software, but to service it so that the data are stored properly and protected, and you get access to the reports and other modules that will become available.
Are the decision tree algorithms themselves going to be open? Not the code itself.
Well, so the book, the decision tree is published. It's in the book. The algorithm will be explained in an online document so that you can actually open it up, and it's even been pseudo-coded so it's readable in English, but it's actually the it's not the source code of the software programming, it's the decision tree code.
Okay,
And that's going to be
that's for
completely
public
available.
available.
Thank you. Ken?
Yeah, two questions, and these are very basic questions.
Very basic questions that you may have answered and I just didn't hear the answer. One, can I assume that because this product is going to be EHR compatible across a number of platforms, that ultimately the results of my interview with the patient will actually upload also into my EHR?
Yes, so if your system has an EHR, actually let me ask you a question. How many people in the room work in a facility that has an electronic health record? Wow, it's like 90%, okay. And actually that was the case in the first group too, at 10 a.m. in the workshop. So we're obviously attracting a group that's knowledgeable about this. So because the standards are being observed, your vendor, or you can contract FEI to do this, will pretty easily, that is without any technical obstacles, be able to link the fields from the ASAM software to your EHR. If new fields have to be constructed, there'll be a standard way to do that. And that's a consulting gig for somebody, because you've got to marry these things together. But it's designed to be readily available to do that.
And then the corollary of that question is, presumably part of your vision at some point year to 5 years down the line is that by the standardization of these kinds of questions and data elements that you are going to capture, you can then design performance metrics that are extractable from this.
Beautiful. So, states. In the first session this morning, we had 2 medical directors for states. Is there anybody from a state official or state medical director in the room right now? Okay. So they were very interested in this kind of thing. There are a couple things that will be easily reportable. So for instance, with repeat administration, change over time. But you'll be able to look at change over time, case mix adjusted by patients of a certain level of care need and subcategories of need as well. So it'll be possible to do very intricate matching, especially as you start to get hundreds and thousands and tens of thousands of patients. And it'll be possible to benchmark your program's success over time with patients in recovery compared to other programs of a similar level of care and even similar baseline patient characteristics.
And even internally as well.
And even internally as well. Another tool that states are going to be interested, we think, in is needs assessment. How many times have you thought a patient would really be ideal for, pick a level, day treatment, partial hospital, and there just ain't one, okay? And so you're stuck arguing with the managed care company that says this patient will cover for, day treatment, and there isn't one. So you want to admit the patient to the next least restrictive level of care, but it turns out it's a residential program because you don't have the option. So this will allow states and counties to see that they're getting X hundred recommendations a year for partial hospital in the following zip codes, and they're not funding any. So the needs assessment opportunity in this is going to be wonderful.
Over the next 4, 5, 6 months, many of the states have been looking into the integration of their mental health with the substance use programs. As you know, in Maryland, we're already there. A lot of stuff is in motion. When such an event occurs, a lot of the bidding goes out to various kind of organizations of how all the data is going to be integrated, etc. So depending on which company ends up getting it, there's going to be a very high influence on these patient assessment areas. We hear a lot of maybe DSM-4 criteria being used in some settings for them to make such decisions and how readily set up they are and whatever they're doing. So with something as critical as this and something that is as meaningful and more relevant as we go forth in in medicine and in accountability and performance measurements and accreditations, etc. I think it is very timely and very critical that this information be brought at the highest level in each state in such an organized manner that they realize that what they should be looking at is the future, not the convenience and the comfort of the same old, low-hanging fruit methodology. Because once they grant these contracts, or once they go into these bids, it is going to be very difficult to change stuff.
Yeah, there are a lot of ways these data will be helpful for the accountable care organizations, the pay for performance, hospitals are starting to get penalized for preventable readmissions within 30 days.
But they need to know about it, that's all I'm saying.
And that's right. But the beauty of having SAMHSA taken on this project for us, for ASAM, and making it available to the entire field, is that the government is behind it. The government has backed it, and they're going to take it forward with CMS and with the other federal agencies. There are a number of federal agencies involved in quality and in healthcare monitoring, and they're going to have a tool that they can bring. Prior to this, there was nothing they could really bring. So this makes a big difference, and I love the strategic thinking you're doing there.
Time is of essence, that's what I'm saying.
I do want to make sure we get any questions about the report. You've had the report of this case handed out to you. On the last page is a clinical summary of this patient, so that when you read the report, you should, review the clinical summary so that you see why the report came to these different scores. And then in the report, you'll see it's not yet including a full formulation or psychosocial summary, but we will be working on that because it's going to be very easy to do. All the data are there. We didn't want to release something that was kind of quirky or had funky language. And to get it to be really a natural language report takes a little bit of work, so we will put that work into it. But the report has the ASI graphically and quantitatively. It has the DSM diagnostic criteria, and for each substance, it actually has the diagnosis and also how many criteria were met, which is going to become, in DSM-5, an indicator of severity. It has hazards and risks and so forth. And then at the end, I hope you can see that there are multiple levels of care that can be considered. And it has a graphic representation of how the software and the book get to an overall level of care set of recommendations. So before you leave, there is another button to click. And what I'd like you to do is go back to your computer and click on the, how did they get to the survey?
First, close the browser.
Oh yeah, close your browser,
Top right-hand button.
your top right-hand close button.
And then there's an icon on your desktop for the survey or workshop survey.
You may double click that. And ideally, if there are two of you, if one of you could do it first and then pass the keyboard to the other person and then the other person fill it out. So take 2 or 3 minutes. There are only 10 questions. And if you can fill this out now based on what you've seen, that will really be helpful.
And before you leave, next steps regarding the software. As I said, we're actively recruiting some alpha pilot sites. And we have a website, asamsoftware.com, that you can go to find the current status and also see this presentation, get access to the demo site if you want to show some of your coworkers or go through the whole assessment yourself. And there's brochures back here on the table you can take with you, but if you happen to forget, just Google ASAM software, you'll find that link. And that site is available now. Thank you.
Thanks for filling this out. you can see that there's more work to do, but we've got a phenomenal team for doing this. Paul Early, who remains on ASAM's board, is providing technical support and input to FEI because of his history as the originator of the software. And so he and I and David B. Lee will work with FEI to continue to refine this. But hopefully you can see that it's taken us since 1994, when I wrote the first grant to computerize the ASAM criteria. It's taken us almost, is that 20 years? 19 years at this point. But we're at an intersection of parity, the Obamacare legislation, and health IT funding that is the perfect moment in time for this all to come together. So with your help, I think we're going to realize something I've dreamed about for many years, which is a patient who walks in the door of a program in Pasadena and a patient who walks in the door of a program in Peoria get asked the same questions about their biologically driven psychosocial spiritual disease, get the same depth of probing, get the same